Hi, good morning, everyone. I am Morgan, family nurse practitioner, and I will be joining you guys today. And we are going to talk about everything respiratory. So I'm just getting things set up here. If you have a moment, I'm going to have you go ahead and get your phones out. If you're, watching from us, then you can go ahead and go to this website. And go ahead and get into this. I'm going to do it with you just to make sure everything is working. And because we're going to use this Slido to answer questions and be really involved in today's lecture and help you hopefully learn the best possible. And if it looks like it is up and running, and you can just hit join on that. Um, and we'll get started here in just a moment. Just a little temperature check. Can everybody hear me okay and see me and see my slides? Just want to make sure we have so many, we're streaming in lots of different places today. I just want to make sure it's working for everyone. Um, Q&A. Yes, you can hear me. Thank you so much. And let me see if I can enable the chat here. Um, Everyone can chat. There we go. All right. So it's just me today. If you have any questions, go ahead and put them in the chat. You can also do it anonymously in the Q&A. I'll try and look at both of those. Um, so go ahead. Thank you, Tracy, for responding. That's so helpful. And we will get everybody up and running, and let's talk about some really cool things. So you probably have heard, as we've been doing these webinars, that we are now able to offer continuing ed. So we do have to do a disclosure. So this is a 1 hour webinar. It's a 1 hour free contact hour for nurse practitioner students or nursing students. Go ahead. You'll get that certificate today. Download it and put it and save it in your file with all of your other continuing ed. I highly recommend keeping good track of all of those things so that you can, when the time comes to renew your licensing and so forth, it's really easy to do. Um, Okay, so we have that 1 hour and then just our learning objectives. We're just reviewing the whole respiratory system. We're going to go over some of those abnormal findings, hopefully like normal and abnormal, so you can really understand what those things mean and then what we do about it. So kind of the most common situations that we see within the respiratory system and kind of how we diagnose and go to that next step of treating it. Okay, so we are going to use Slido. I love Slido because it makes me feel like I'm actually talking to people and not just into the bliss because I am sitting alone in an office. So I do like this interaction. So if you can pull out your phones, I know we never say that, but pull out your phones today. Don't open any Instagram or anything like that. Try to just stay with me for 1 hour, if I can have your attention for 1 hour. And tell me where you are visiting from. All right. I got a lot of interesting. Okay, Madison, Mississippi, Nevada, DC. Oh, I was just out in DC. I love DC. It was my first time out there. Wow, what a beautiful city. I was there for the Obesity Medicine Conference in National Harbor, Maryland. Such a nice place. And if you're interested in doing obesity medicine in the primary care setting, I highly, highly recommend looking into the Obesity Medicine Association. They're really, really great. Connecticut, Nevada, New Jersey, Florida, sunny California. Awesome. I'm in Denver, Colorado today. It's actually kind of a cloudy day, and then which is strange for us. We get a lot of sun out here despite having snow in weird times of the year. But right now it's been really warm. Um, Thank you guys so much for your participation. We're going to keep that app open or that part of your phone open today. And as we go through some of these questions, it's a great way to just kind of practice some of the board's questions and how to approach them and what to think. And this is no stakes today. This is all just about learning. And then we'll try to get to a case study. I tend to talk too much. Ethiopia, that's so cool. Great, welcome. So all over, yeah, if you have any questions, you can always reach us at Archer. Um, Let me just go back here to this website here. So you can talk to us at nurse practitioner at archerreview.com. Guys, if you are getting ready to graduate and sit for your boards exam, We have a 3-day live review, May 28th through the 30th. We have expanded it. We have added a lot of content. It is going to be very, very good. It will get you ready for that board's exam. And I really, really, really suggest it. We have the on-demand content, little bite-sized videos, or go more in depth, whatever it is that you need, and then tons of practice questions and those practice tests. So that readiness predictor. I recommend at least 4 weeks of studying, taking that readiness predictor test 4 different times to really make sure that you are ready for that board's exam the day of. Okay, guys, let's jump in. Oh, I didn't switch my screen. This is what I'm talking about here. You can scan this QR code to register to hang out with us for 3 days at the end of the month. It's after Memorial Day for those of you that are in the United States. But right after, hopefully, graduation or right before graduation, this will just get you really, really ready for your exam. Okay, let's dive into the respiratory system. Oops, come back over to this screen. Working on so many. All right, and we talked about our learning objectives. We got into Slido, and now we're really going to kick things off with our lung exam. Okay, I'm the first to admit when I was a nursing student, it was difficult to listen to these different lung sounds and really understand what they all meant, hear the kind of differences between them, but it takes time. So I just suggest always listening to people's lungs because that is how we get good at our exam skills. So we want to pick up on those subtle nuances and sounds that really help us understand what is pathologically happening inside of the lungs. So let's just start with the basic normal lung sounds. These are known as vesicular. So I just remember the letter V. All right. We really have nice, soft, low pitched sounds. And this is indicating that air is moving flowing smoothly throughout all of the lung fields. So you want to make sure you listen in all lung fields. Remember, we have a right middle lobe. We do not have a left middle lobe. That's where our lobe, that is where our heart lives. So we don't have any lung tissue over there, but we want to make sure that we listen to all lung fields to ensure that we have that vesicular sound happening throughout there. But then we have some of these brash sounds that can indicate potential issues, right? So our first one we're going to talk about is rhonchi. This is an abnormal breath sound, and it really indicates airflow obstruction. They have this characteristic low-pitched kind of snoring sound. It's probably the easiest one to kind of pick up on. And they're really, really heard when patients are congested with mucus kind of obstructing those airways. All right. They can also be heard with some sort of like inflammatory condition, like a cystic fibrosis, or at some point in pneumonia. Okay. Next up, we have rails. You've probably heard these referred to as crackles. We have two different types. We have fine and we have coarse. Fine crackles are those short, high-pitched pops, while those coarse crackles are a little bit lower pitched and they're going to last longer. When we hear rails or crackles, we expect to hear some like kind of strange rattling, clicking, bubbling sounds. Okay. We hear them mostly on inspiration. And what they're telling us is there's some airflow impairment throughout the lungs. We think of air kind of moving through some water almost is what it sounds like. We think of pneumonia, bronchitis, pulmonary edema, chronic conditions also like COPD can have some of these going on. Move over to wheezing. Wheezing is that high pitched sound. You've heard this as the wind. If you've ever been in a windy city and the wind is kind of squeezing through things and you can hear that, it's kind of an eerie sound. The same thing. So that's like when wind is kind of moving through or air is moving through a really tight area, a tight fitting space. And so we can hear wheezing as well in the lungs. And what it signifies is a narrowed airway. Okay, so we think of wheezing associated with asthma, where we have inflammation in that airway, and it really is, it's a tight space that that air is trying to move through. It's constricted. We have a little bit of a caveat here. So if you hear that wheezing sound more up in the neck area, we actually change the name from wheezing to stridor. Both are indicating like a narrowing or obstruction or constriction of that airspace. And they just have different names depending on where we're listening. So if you're listening in the back, on the upper, you might hear some wheezing as you move through that lower, mid and lower lung sounds over to the right as well. You could hear wheezing, but the moment that you hear that same sound up in the neck area, the name changes to stridor. Same kind of thing. I think of stridor a little bit more often with the foreign body obstructions. So somebody kind of like a kiddo swallowed something. Maybe it's not obstructing terribly, but enough to cause this kind of abnormal breathing. Not great. We need to do something about it. We could also think of alert like allergies, like a severe allergic reaction, smoke inhalation, or head and neck surgeries can also cause stridor when we get some inflammation in that airway. All right. Last up, we say absent or diminished. So if we don't hear anything at all, this is a red flag. We call these absent lung sounds, which should really clue us into potential issues that the air or fluid is in the lungs too much, right? So nothing's moving. We don't have any movement occurring any longer. We think of things like heart failure. So when the lung is just really full of fluid, it's too full of fluid. So the pressure of our breath in is no longer moving the air like it was in the rails. It's now to the point where it can't move that fluid. It is, overall very much kind of filled up. We also think of advanced pneumonia or a pneumothorax. So now we don't have our lung expanded. That lung is completely collapsed down. We're not moving air into that tissue. Severe emphysema can also be something that we see. One little thing, if you are not hearing anything, this is always going to warrant further investigation. One pro tip, make sure they have lung tissue there. Make sure there wasn't a lobectomy, right? We can take parts of the lung out. So if you're listening to that right lower lung, middle, right middle lung, you can't hear anything, and you want to send this person to the emergency room. What is going on? There's no, well, ask them, make sure they didn't have a history of a surgical removal of that part of their body, because that can happen. All right, here's just one more kind of quick look at these different sounds. If you want, go ahead and take just a screenshot of this. It gives a little bit different kind of descriptions here that I think can be helpful, and also the causes. Give you just a moment. Okay. All right, common colds. If you work in primary care, urgent care, if you work with pediatrics, you're going to see this. People are coming in, post-COVID. Folks are just a little bit more nervous. I think I see that kind of calming down just a little bit. But immediately after COVID or during COVID, everybody came in for their upper respiratory infections, right? They wanted to make sure it wasn't COVID. They were very worried. But this is something that you're going to see here. So very, very, common. We have the rhinoviruses, other respiratory viruses. Typically, they spread through drops, and the symptoms are usually pretty mild. Start with a little scratchy throat, maybe some sneezing, runny nose, stuffy nose, cough, congestion, maybe even a mild fever could be present with just the common cold. When we do an exam, our findings kind of look like maybe some red, swollen turbinates, and then also in their throat, we might see their pharynx just a little bit more erythematous, may be able to palpate a little bit of their nodes, as well as their immune system's kind of kicking in. We might have clear or lightly colored nasal discharge, but we can confidently diagnose the common cold based on kind of their clinical symptoms alone. We want to rule out, oftentimes you're going to rule out flu or COVID. So we have the flu-vid test, right? And that's why people are usually coming in to see us when they have a common cold, because they want to make sure that they don't have something really infectious that they might need treatment for, or isolation. I guess even if you have the common cold, you should stay home until symptoms are better, just to reduce spreading of that. But it's totally fine that we get a flu-vid test if it makes us feel better as nurse practitioners. As we're getting more advanced into our careers, it's kind of easier to like pick it up, that this is, you don't have any body aches, no fevers, no chills, your appetite's still okay, you just feel kind of a little bit under the weather, probably just the common cold, because we know that things like flu and COVID typically come a little bit heavier. However, if you're vaccinated, you might present more like the common cold. So getting that test, if they're in your clinic, I would probably just do it to rule it out. When we're treating folks for the common cold, it's really just symptom relief here. Rest, hydration, we can use over-the-counter decongestants, pain relievers if necessary for the throat. make sure you're choosing the right decongestant. So, like a patient with hypertension or a history of urinary retention, we don't want to do some of those different decongestants over the counter. We can make those situations a lot worse. So, just kind of keeping an eye on those things. I really like just tea, honey, rest, taking care of yourself at home, staying at home until you feel better. And then prevention, right? We talk about hand washing, avoiding sick contact, staying home when you're sick, stuff like that to kind of really help. Okay. Um, Pretty mild, right? These folks, they're mild appearing. We move on to bronchitis here. Really also a pretty common respiratory condition. We characterize this by inflammation of the bronchial tube. So now we're starting to see some actual issues occurring down into that lung space, right? So those bronchial tubes starting to get a little inflamed as a result of like a viral infection. It could just be from the common cold, it could be from flu, it could be from COVID, but we're seeing inflammation there. We could also see this as a result of a bacterial infection, even irritants. So if you live in an area where you might have a lot of smoke during the summer months, right? So, California had big fires, and in Colorado, we have big fires here. That type of irritant can also cause a somewhat of a bronchitis type presentation and inflammation, depending on lung sensitivity and how much time you're spending outside during those really poor air quality days. That's why, they typically tell you, hey, public health recommends that you stay indoors today when air quality is getting bad. In Beijing, they also have some of those days where they kind of say, like, hey, you should definitely wear a mask or maybe don't go outside today. We were there with our kiddos. And so that was an interesting kind of new thing for us to say, oh, yeah, air pollution today. We can't quite get outside. All right. Symptom wise, we really think of these folks kind of initially experiencing a nagging cough, just kind of won't go away. We could see an increase in mucus production, maybe a little chest discomfort from that coughing. So those muscles can get sore, those intercostal muscles. So costochondritis can occur along with any sort of respiratory issue because you're coughing, coughing, coughing. You're utilizing these muscles a lot more than you're used to using them, right? We just breathe all day, but we're not forcefully trying to expel things. And when we're using those muscles in that way, you can actually palpate the chest along those um, uh, the costochondritis muscles there and really feel and they'll be tender to the touch. And that's kind of a good indication that there's probably a costochondritis going along with the cough. We can have a little bit of that, that discomfort. We could also pick up on some wheezing because we do have airway inflammation. And it can be acute, which is, lasting less than 3 weeks, or chronic, more than 3 weeks. When we do a physical exam, we might see things like a mild fever, fatigue. I say they're, if they're coughing a lot, for some reason, coughs always tend to get worse at night. And so it really interrupts sleep. So you're going to feel tired. You may have some body aches. A productive cough is also there. Like I said, we might pick up on some wheezing during auscultation. Our diagnosis is usually clinical here. Okay, we talk about their history and symptoms, a chest X-ray, a CBC, fluvid. Those things would help confirm our diagnosis and rule out any of those other presenting etiologies. But again, it's up to you, and you're gonna probably, as you're getting into your career, you're gonna order more and more tests, which is okay. And then you're gonna start kind of getting that repetition of patterns and being able to kind of link, okay, I saw this is what I think it is, and be able to use that. They say about 10,000 hours before nurse practitioners or clinicians in general really start understanding and seeing patterns in clinical presentation of different things and feeling confident in relying on those things to diagnose. So 5 years. 5 years of practice before you're like, getting that really good gestalt of clinical practice. So just use your technology that you have to go ahead and diagnose and really start to understand. And that's how we learn, right? We just see on repetition, 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 and we'll eventually we'll get it and it'll become easier. Those first 5 years in nurse practitioner life is challenging but fun. All right. Acute bronchitis, really self-limiting, supportive care, rest, hydration, we may use over the counter. I like Tessalon pearls for cough management. seems to work really well. Folks like it. For chronic bronchitis, though, we might get a little bit more complex. We may actually need stuff like bronchodilator, so our albuterol. We could need some corticodes, either inhaled or possibly systemic. Maybe we're going to think about some antibiotics, kind of depending on what their presentation is and how long they've been presenting and what other comorbidities they have, right? We're going to consider all of those things when we're deciding how to go ahead and manage this. All right. Now, COVID, I'm not going to beat this too much. We all know so much about COVID, I think, at this point. But it is caused by the SARS-CoV-2 virus. Very, very contagious. It's still out there. Most people at this point have been vaccinated or exposed, so that kind of is helpful. Um, I do recommend vaccinations still, but what we see with these folks is um, super contagious, spread through kind of that air droplet. So coughing, sneezing, talking, or just being in close proximity. Remember, we had that like kind of 6 foot or like a meter, I think it was, distancing that we did. Social distancing, if that rings the bell, it's kind of crazy to think back on those times. But we really think about their symptoms here, and folks, I just had a patient with COVID the other day. He called me. He was like, "I swear I have strep throat. My throat hurts so, so, so bad." And I said, "Do you have a cough?" And so, whenever we're thinking about strep, a cough and strep usually don't go together. So, if there is a cough present and they have a really bad sore throat right now, that's what I'm seeing in clinical practice. I'm kind of almost always leaning towards more of a COVID diagnosis versus a strep or influenza is kind of slowing down in our area, but COVID just seems to kind of always hang around. Um, I don't know what you're seeing throughout the world in Ethiopia or in Florida, DC, but definitely something kind of interesting. Oh, I have somebody put in a question. 3 days to the offer. Oh, in June and July, it kind of depends, but yes, for the 3 day, let me get back to you on that, Tracy, and email our nurse practitioner people, okay? And we'll get that done. Okay. Um, Okay, so with COVID here, we think again of that dry, unrelenting cough is very pretty characteristic. And then some people just have really mild symptoms. So this is what makes diagnosis hard, and this is why getting that fluvid test in your clinic or just a COVID test at home. So like with my patient, I saw him over a telehealth visit, and I just said, "Hey, is there any chance you can get a COVID test?" His wife went and picked one up. Sure enough, he was COVID positive. And so kind of like utilizing those different things. But what we see here, chest tightness, shortness of breath, we might have kind of that loss of taste and smell with these folks. Um, Flu and COVID can present very similarly. So it can be a little bit hard to diagnose, differentiate those just based on clinical symptoms. That's where we do rely on our testing. We know that COVID can lead to respiratory failure requiring mechanical ventilation and death. So that still exists, that risk still exists. And so that's why in the primary care setting in preventative medicine, we should consider and continue to advocate for folks to get their boosters, especially based on their risk factors, and stay up on vaccinations. We can prevent hospitalization and death. It's not, none of our vaccines are 100%, but they do help us reduce morbidity and mortality. We know that for sure. We've seen that with the measles outbreak all over, happening again, unfortunately. All right, pertussis, another preventable illness through vaccination. Pertussis, really common and known as the whooping cough. So I lived out in Seattle. That's where I did all of my training. We had a pretty low vaccination rate in one area, and we saw a whooping cough kind of outbreak happen there several years ago. I couldn't even tell you when it was. I swear, COVID timeline has like completely erased my ability to like recall when events happened. Um, but anyways, when we see the whooping cough, we typically think that folks that are infant, I mean, we could probably say this for every respiratory illness. Infants, pediatric patient populations, and elderly populations are at the most risk for severe morbidity, mortality related to any of these things. And it's the same for pertussis. Okay, we see it very, very commonly in that infant population. It's caused by the bacterium Bordetella pertussis, and it spreads through respiratory droplets. Symptoms often start out kind of just like a common cold. We have a little bit of a runny nose, a little bit of a cough and sneeze, but then they get worse and they get really bad if we are unvaccinated. It can be uncontrollable coughing fits. They have a distinctive whoop sound. If you haven't heard it, I encourage you to go onto YouTube or some other channel to listen to what that sounds like so that you can kind of distinctively understand, oh, that is what a whoop sounds like during a pertussis infection. It's usually heard upon inhalation. So when they're trying to get air, as they're cough, 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 and they're trying to get air back in, is when you actually will hear that whoop. These fits can get so bad that you can actually see central cyanosis occurring in the child. This is pretty severe. It can end in vomiting. Again, that can be pretty classic picture. So my kid is coughing so bad to the point where they're turning blue and throwing up. That should get you thinking about a possible pertussis infection. So what do? We test. We use the PCR testing to detect the presence of the bacterium in their respiratory secretions. We offer supportive care. They may need inpatient care depending on their age and risk factors and how they're presenting. We use antibiotics. Erythromycin, azithromycin are common. We also treat the family. So if you've been exposed to it, it's so highly contagious, we'll go ahead and treat the whole family with antibiotics. Really important that we educate parents on the importance of that DTaP vaccine in childhood. And for parents who are bringing in a new baby, making sure they're up to date on their tetanus, diphtheria, and pertussis. It's a really, really important thing. We actually vaccinate all pregnant women, or we encourage all pregnant women to be vaccinated and their partners and their family members, especially during those winter months when we're all close, we're kind of locked inside. That's when we see these things typically kind of spread. So again, vaccinations. Okay, pneumonia. This is a big one. It's important to know we have different reasons, different kind of etiologies. What we're talking about here, this heavy weight in the respiratory world, the different conditions, this is something that you're going to see and you need to know what to do about it because it can get bad fast. Pneumonia invades the lungs, causing inflammation in the air sacs or the alveoli. Okay, and we think of different types, so we'll talk about all of those here. But just for a little bit of a quiz and something to kind of break up this lecture, let's go through some of our exam findings. Okay, so a special technique, and we didn't talk about this today. So the nurse practitioner is completing a physical exam on a geriatric patient with pneumonia. Which of the following would be expected on auscultation? Wheezing, stridor, ergophony, or that meaty acidental crunch? Okay, I'm going to have you pull out your phones and answer if you can with me here. And let me just, oh, I skipped a question. I'm sorry. I usually ask who's with us today. My apologies. And I forgot okay, sorry. Okay. Um, let's see here. Wheezing and pneumonia. Yep. Egophony. Yes. Can anybody in the chat tell us what egophony is? Anybody want to try to answer that? E sound, yes. Okay, so the correct answer here is egophony. I'm gonna have you guys, if you're staying in there, can you just answer this question for me? I have to do just a poll. Real quick, how confident do you feel in your ability to assess patients with a respiratory complaint on a scale of 1 to 5, with 1 being not confident at all, 5 being completely confident? Where are we at here? Just before starting this lecture, my apologies. I just jumped right in this morning and I forgot of all those questions I made in this wonderful Slido last night. Okay. Awesome. So we're kind of in the middle range, which is where I want you to be. That's perfect. Sometimes I feel more confident than others, and I've been doing this for 5 years. So, yeah, that's kind of just where we want you to be. Okay. Thank you for doing that. Let's head back over here. So the correct answer to that question is the agophony. Okay. And so when we hear agophony, what we're talking about is the sound. We have the patient say the letter E. And if I listen to my lungs without pneumonia in them and no consolidation in that area, what I'm going to hear is the letter E. It's going to stay that same sound. However, if there happened to be some consolidation in that part of the lung, that sound would actually change to here. You would actually start hearing A sound instead of E, but they're saying E, and when you listen down there, it changes it. So I wonder if you could test that like in some water or something, and if you would. No, I don't know how you could. I don't know how you could like kind of mimic that. I guess a YouTube video would probably be the best way to hear that. Um, all right, just a quick review. So wheezing we could actually hear in pneumonia. So that answer is not totally wrong. Okay, we could definitely pick up on some wheezing. More characteristically of pneumonia, though, I think of those rails or crackles around that consolidation area. And then as it gets more inflammation and stuff like that, we could hear some wheezing happening. Wheezing really common in our obstructive airway, things like asthma, COPD, and bronchitis. Okay, stridor, that's up in that upper airway. And then that mediastinal crunch, non-pulmonary, that's with a cardiac contraction, has to do more with the cardiac system there. Okay, chest x-rays. Guys, I am not going to teach you everything you need to know about chest x-rays. When I first started out, I did a nurse practitioner residency. We had an x-ray in the house, and we did wet reads on all of our patients. It was amazing. And then I left my residency, moved to Colorado, and I never saw another chest x-ray. I only get reports. So I am not super, super good at reading these, but we know that we want to have a systematic approach. This is a lecture in and of itself, but let's just go through these things really quickly. So when we think of a systematic approach with chest x-rays, we can think of A, B, C, D, and E. Okay. When we think about A, we're thinking of airways. We start at the top. Is the trachea midline? We follow it down. We look at the carina. We check for any narrowing, displacement, or foreign bodies. We're really tracing out that main bronchi, any cutoffs, anything different there. Then we go to B, which is breathing. We evaluate both lungs. Do they look equally expanded? Is there any sort of asymmetry? Are there abnormal densities, lines that aren't vessels, right? We can see that vascular system. We're also going to check for those costophrenic angles, that sharpness. We're going to look at the diaphragm. We're going to look for the stomach bubble. Are we seeing those sharp, visible borders? That's what we're thinking about with breathing. Really symmetric lungs. C, we're thinking of circulation. So we're going to check the heart size. It should be less than half the chest width. Is the heart positioned to the, 1/3 to the right or 2/3 to the left? Evaluate that aortic arch, the pulmonary trunk. We're going to look at the hilar vessels for size and symmetry. And we're just thinking C for circulation. Okay, D, disability. So we're thinking of bones most specifically. We're going to look at the ribs, starting at the clavicle, looking at the spine, shoulders for fractures, lesions. Are the vertebrae intact and evenly spaced? Those are the things we can kind of look for here. And then E is for everything else. Now we're just scanning the upper abdomen. We're looking at soft tissues, looking for free air, subcutaneous emphysema. Are there any surgical clips? Is there anything strange? Is there an absent breast shadow? And then we're going to look at that retrocardiac and retrodiaphragmatic area. All right, common findings that we think about pneumonia really is going to show up as those white patches that you can kind of see over here. And dark, kind of more, the pneumothorax is going to be a dark space. So here we can see that we don't have a fully expanded lung. We think of effusions more hazy in that like lower lung. Again, this takes lots and lots of practice to be able to read them. And if you have the opportunity, do it. I did it for a year. I feel like I've kind of lost my practice in this, but really important. Okay, I'm going to give you one more look. If anything of today's lecture, you feel like, goodness, I kind of want to review that in a little bit more depth, go ahead, linked up with us. We have so many good things at Archer, you guys, and we are here to help you. So if it's tutoring, mentorship, or the content that we work day in and day out creating, we want to share that with you guys. And then again, that 3-day live review that is coming up. If you missed it at the beginning, I just wanted to let you know it's May 28th through the 30th. It's going to be really great, you guys. We have revamped our slides. We are just got a new team on board, and we're going to have such a great 3-day live review for you to make you feel ready for your boards. All right, let's keep going with pneumonia. So first up, we talked about all those different types. So we're going to go through all these different types of pneumonia. First up, we have bacterial pneumonia. We think of different pathogens like streptococcus pneumoniae, the H flu, mycoplasma pneumoniae, and we think of our symptoms. These symptoms can range from cough, fever, and chest pain to really serious things like respiratory failure, confusion, cyanosis. Important if you have an elderly patient, they're confused, UTI, pneumonia, what could it be? We want to consider all of those different things, okay? If we have a change in mental status from their baseline, we don't assume that they just got dementia overnight. We assume something probably infectious is happening in their body, okay? Or medication error. On physical exam, it's really not uncommon to hear what we talked about, those rails or crackles. We could even get some decreased breath sounds in those lungs as the pneumonia gets more pronounced and as that consolidation gets worse. But our gold standard is really looking at a chest x-ray and seeing consolidation or pleural effusions. I like to order a CBC looking for a white count. We could consider a respiratory PCR. I don't get those often. I'm guessing that's more inpatient. That would be done. Blood cultures, if you're thinking maybe that there's some sort of more widespread infection. It could have started in the lungs, but now we're looking at sepsis or something like that, especially in our immunocompromised folks. So they would consider doing something like that. Not often in the primary care setting. If somebody's looking that ill, they're not staying with me. I'm sending them over to the emergency department. All right. Treatment wise, depending on their stability, we're going to use antibiotics in the outpatient setting. We're going to think a little bit about it, and we're going to really use an antibiotic specific to the pathogen. So penicillins or macrolides kind of being the common choices. And we have some really, you can see all of these. There's a great antibiotics lecture that is going to be in that 3-day live review to kind of understand which antibiotics for what. I wish I had that when I went to school because it would be it's super helpful. All right, viral pneumonia. These guys, well, they're caused by viruses, okay? Influenza viruses, the RSV viruses, adenoviruses, all the coronaviruses, COVID-19 being included in that. They're all common culprits for that viral pneumonia. When we compare viral pneumonia to bacterial pneumonia is a little bit more quick. People with bacterial pneumonia, they're going to present quicker with a more rapid onset. They're going to get sick quicker. Viral pneumonia tends to be a little bit more gradual of an onset, and their exam findings might not be as like in your face. Okay, so we don't want to miss it because they don't perhaps appear quite as ill as somebody with a bacterial pneumonia, but that doesn't mean we ignore it and let it go. We can really rely on lab work like a CBC. We're going to look at a CMP. We're going to look at rapid testing to rule out the different things, right? Is it RSV? Is it influenza? HSV can also cause something like this. Chest x-rays are still helpful. And with viral pneumonia, we might see a little bit of parenchymal defect that can kind of help us confirm that diagnosis, but might not look like that, that consolidation that we see in a bacterial type presentation of pneumonia. For treatment, really, again, we're focusing on supportive care, making sure they have help at home if, depending on their status. So that's one thing that I always consider. If I have an elderly patient who presents, with a pneumonia, regardless of what type, if they are living alone and they have very not great support, nobody can come stay with them or check on them, that might make my decision a little bit harder as to whether I keep them inpatient or outpatient, depending on how they're presenting. Because if they go down quickly, do they have a means to get the help that they need? And can they reliably take care of themselves, get themselves enough, of the supportive type care that we want? Wow, like, can you make yourself some soup if you're feeling so bad and you're kind of elderly and frail? That might not be common. This is this like kind of like balance, and that's where medicine becomes an art, where you're having a conversation with your patient and you're really following up quickly to make sure they're okay if you're sending them home. These are the people I kind of lose sleep over because no, they don't want to go into the hospital, and I don't want to send people there because I know that there can be risk factors just associated with hospitalizations and exposure to a lot of those superbugs. So this is this conversation, and these are the people that I'm calling it, 8 o'clock at night, just double check and make sure everything's okay. And again, 8 o'clock in the morning, making sure that they're okay. If I do send them home. Now that's probably, that's it depends on what you do as a nurse practitioner. I'm not saying any that you have to do that. It's just my own kind of concern whenever I see patients that I'm a little bit worried about, that we through conversation decide that they're going to go home and when they're going to be okay. Um, all right. When we're thinking about this, again, we're really thinking about that kind of just supportive care. Potentially, we're going to give them a Paxlovid or a Tamiflu, depending on what they come back positive for. Ribavirin for RSV, varicella. We could do something like a cyclovir, depending on what we think they have. Right. We're going to treat with our antivirals as well, and their risk factors again. These viral pneumonias can kind of move their way into a bacterial pneumonia. So just something to keep in mind. Yeah, we think it started as influenza, but now we think that they're presenting with a bacterial type infection. We can see that kind of progression as the immune system's down and if they come in contact with something. Okay, we have atypical pneumonia. This is kind of caused by less common organisms. We think of all of these guys over here. You've all heard of the Legionella pneumonia. But it's hard to kind of put two and two together with these guys because their symptoms can, again, be a little bit milder with this atypical pneumonia. They might have things like headache, sore throat, non-productive cough. We have to dig in a little bit further to diagnose this. So we'll rely a little bit heavier on that PCR and serology testing. Um, Kind of the most useful, and treatment usually involves like a macrolide or fluoroquinolone to combat some of these atypical pathogens. All right, we're going to have another quiz. So, history and physical findings identify a case of community acquired pneumonia in an older adult patient. Which of the following, this is a tricky one, which of the following can help identify if this patient requires collaboration for a higher level of care acutely? So we talked a little bit about some of our decision making um, around folks that maybe don't have great support at home. But how do we know when we absolutely have to send somebody to the emergency room and get them probably admitted to the hospital? Is it, and I'm gonna bring us back here. Oops, sorry, let me go to that question in our poll. All right, so we have the curb 65, we have bronchoscopy, we have a pleural fluid culture, and we have chest x-ray. What do you guys think? I'm going to take a sip of my coffee here. All right. Seven of you, eight. Amazing. You guys are great. Yes, that is the correct answer. So we use that curb 65 index. And what that is, I'm just going to go here. You're going to get a chest x-ray, right? We decided that we definitely want a chest x-ray. That's how we diagnose pneumonia. But when we're making that decision, do we need to send them to the emergency room? We use this curb 65 indicator. If there's any point of confusion, we're going to send these folks. If they're BUN, if you can happen to get a CMP and get that result back, if it's above 19, if their respiratory, I hope this is pretty obvious. If their respirations are above 30, or their blood pressure is low, or they're over the age of 65, we're going to give them a point system. Okay. And 0 to 1, we can do outpatient. We can feel pretty confident. So this is the patient that I'm like keeping me up at night. Maybe they have a score of 1, right? Maybe they're just over the age of 65 and they don't have great support at home. That's like, because you can see here when we get to 2 points, now we're already sending these folks into a higher level of care. And that's what's just a little bit kind of, like I said, this is what's going to kind of keep you up at night as you're becoming a nurse practitioner and getting more and more comfortable with your patients. And that's where I say, if you're worried, but you made this decision with them, it's okay to follow up. Okay. Depending on how you want to put up your own work-life balance is also important. Just to wrap up on pneumonia, again, I can't overstate the importance of vaccinations. Especially for older adults, we can prevent severe complications from pneumonia and death. So we think of very young and we think of very old folks when we're thinking about these people who are at most risk for severe complications from things. We also think of our immunocompromised folks. So folks with HIV, cancer, sickle cell, diabetes, chronic lung or liver or heart disease. All of those folks should be vaccinated. We're still, influenza vaccines, COVID-19 vaccines, all of those things. Have a conversation, educate yourself. The tone is changing in our country rapidly around vaccinations. And it is something that gives me pause and it gives me hesitation and worry about what the future could look like if we stop advocating for vaccinations. Pulmonary embolisms, okay, acute respiratory condition, PEs. These guys can be fatal if we don't detect and treat quickly. A PE is, a pulmonary embolism or PE. Really occurs when a blood clot, usually from a deep vein of the leg, or a DVT, breaks free and travels to the lungs and it blocks airflow to the lungs. And then it just kind of grows in size, right? So now we start getting that kind of coagulation effect. And now we get a large PE that's completely obstructing the lung, can be fatal. All right, so symptoms. We think of, various kind of symptoms. It can come with just a little chest pain, shortness of breath, coughing, and then it can progress where we're starting to cough up blood. We can see that pink foamy discharge from the mouth is also something. Again, we might even just see just like some sweat, and you might think, oh my gosh, is this person having an MI? But you need to rule out a PE as well. Um, we think of the CT, that with pulmonary angiography, as our kind of gold standard to visualize where that clot is. I have a really good friend who is a CT tech, and their job, if they're being tasked with obtaining this, is oftentimes the doc will come into the area and see the result unfold in real time. So as they're getting that CT scan, that pulmonary angiography, the doc is there just like waiting to react right away, is what she told me in her hospital setting. I don't know if that's typical in most, but depending on their level of concern, because this is so fatal, we need to act so quickly. So what do? We're going to really prevent further clotting. So we're going to dissolve that clot and prevent further clotting. Most likely, we're going to use some like thrombolytics to kind of bust it up. There may need to be a surgical intervention to remove that clot directly, depending. But who's at risk? Okay, so when I was on campus during, goodness, was it my undergrad or graduate? Again, COVID ruined my memory for timelines. Um, we had a 21-year-old female who just was walking across campus and unfortunately collapsed, had EMS arrive too late, and she passed away. And it was later determined that she had a PE and birth control was a factor. And this is just something that, we think about. So we think of a hypercoagulable state, and some people can take, oral contraceptive without anything. But if there's a co-occurring issue happening, like a clotting disorder, factor V Leiden, cancer, obesity, autoimmune diseases, pregnancy. And then again, that hormone use increases our coagulable state. And we know, like for menopause, we oftentimes will recommend women to use like a topical type estrogen because it doesn't go through the liver, doesn't cause a second pass effect, and doesn't increase clotting factors. But when we take oral estrogens, especially as we get older, or if we smoke along with it, or if we have a hypercoagulable state already, then those can all come together. Now, pregnancy in and of itself is also a hypercoagulable state. So do not think that I am saying don't use oral contraceptives because it increases your risk of clot, because that is not what I'm saying. Pregnancy is just as risky if you have these underlying things. Potentially, pregnancy is actually more risky than oral contraceptive. But just kind of to remember that hyperestrogen states, for some reason, pregnancy is a high estrogen state, we see an increase in coagulation. Again, factor V Leiden, cancers increase our clotting, obesity, autoimmune diseases, and then testosterone use in men or women can increase a little bit of that as well. All right, any questions as we're going through all of this? Okay, I have another quiz for us. Um, Sorry, I'm moving really slow. I hope this is, I don't think we're going to get all the way through this lecture today, but I'm hoping that these questions are really helpful. All right, so we have a 55-year-old male. He comes in, acute shortness of breath, a sense of impending doom. This is like bold underline if you see that on your test. Right knee at arthroplasty. So we just had a knee replacement a month ago, returned from a cross-country driving trip. This is actually a patient I saw. History of hypertension, dyslipidemia, metabolic syndrome, on the current medications, aspirin and amlodipine, atorvastatin, has some alcoholic beverages, and smokes. No illicit drugs and pretty normal. But you suspect, okay, I didn't see the PE in him, but with my patient, but this is you're suspecting this. So what diagnostic tests are you going to use to rule out this diagnosis? A D dimer, a CT, pulmonary embolism protocol, a ventilation perfusion scan, or electrocardiogram. Okay, so let's go over here and we are going to answer this question. And what is the diagnostic test to rule out? Okay, one person said the CT, D dimer. Okay, okay. Awesome, guys. So the CT, the D dimer plays a role, and you're not wrong in thinking that. The D dimer is not specific and it can't rule it out. It helps us a little bit, right? We're going to get a D dimer, we're going to get an EK, an ECG. We're going to do these things, and we can use the ventilation perfusion scan in a patient who is we can't do a CT on, okay? But our gold standard to rule in or rule out a PE is going to be that CT with the pulmonary embolism protocol. That's where the doc is actually walking in with the patient as that result is coming back full time. They are ready to respond because they're going to want to break that up as fast as possible or make whatever intervention as quickly as possible. So they're, depending on their level of concern and their level of suspicion, if they really think this is a PE, they're oftentimes just there ready to react. And they're using that the CT to get that information. Okay, awesome, awesome. But in that emergency setting, you're going to get all of the rest. You're going to get that D dimer, right? It's really, really helpful, and we use it all the time. But again, it's non-specific. And then all the other things here. Okay, switching gears, we have 10 minutes to cover COPD and asthma and a case study. We're not going to probably make it through all of it, but I'll do my best. Okay, let's talk a little bit about chronic conditions, asthma and COPD. Look, we use our diagnostic tools, the PFTs. We have something called, like PFT for short. This is really, we can get these folks over to our pulmonology friends, colleagues. They can do a lot of different tests and get a full lung function for us to really understand what's going on. In the primary care setting, we oftentimes use spirometry. It's a fairly simple exam. We can help us kind of diagnose between or differentiate between conditions like asthma, COPD, as well as track chronic disease progression over time. So we can see, how are we doing with our treatments? Are we improving things or are we not? So we can use that in-house spirometry to kind of get that information. So our major types of pulmonary function tests are spirometry, right? We could do spirometry before and after a bronchodilator, which is what we commonly do. We have lung volumes. We have that quantitation of diffusing capacity of carbon monoxide. Again, those are really highly specialized tests that we're going to be using at a pulm specialty center. Here in Denver, I often send people to National Jewish. That's the hospital where they are just experts in all things pulmonology, and they help out a lot. And they do these extensive tests to help if I have concerns. So how do I know if I have concerns? Well, I'm going to do an in-house spirometry on folks that come into primary care if I'm suspicious of something going on. Again, as chest x-rays, this is a full lecture in and of itself, spirometry testing and understanding and interpreting, but just a quick refresher. So we use spirometry in the primary care to evaluate suspected lung disease, okay, asthma or COPD, or to monitor unknown disease progression over time, which we just talked about. What is our goal? we're really looking to determine, is what we're seeing obstructive, restrictive, or is it a mixed presentation? So let's kind of review these key terms. We have FVC, forced vital capacity, the total air exhaled forcefully after full inspiration. A low FVC could suggest something like restriction, but full PFTs, that are full pulmonary function tests, are going to be needed to confirm this. Okay. FEV1, we think about forced expiratory volume in 1 second. Okay. The volume of air that's expelled in the first second of forced breathe out. So you're breathing as hard and as fast as you can. In that 1 second, we measure how much is going through. This is crucial for grading obstruction severity, especially in our asthma and COPD patients. We have a ratio. Next, we have this ratio. It's the FEV1 versus the FVC ratio. And this is really, again, helping us detect airflow obstruction. A low ratio points towards diseases like asthma or COPD. All right. If baseline spirometry shows obstruction and there's no clear diagnosis, we often have a post-bronchodilator test, which helps. So if it normalizes, so if we give them some albuterol and their test comes back and it improves, COPD is less likely, right? We kind of lean more towards that asthma. But we may need other workup if symptoms kind of persist. Okay, the flow volume loops, this show kind of airflow over time. Abnormal shapes kind of signal upper airway obstruction. And this might be another reason that we refer over to pulmonology. So our bottom line here, spirometry, it's a great tool, but in complex cases, we're likely going to need some specialty input. Keep practicing these basics and always assess within clinical context, our kind of overall things. So just taking a little bit of a closer look how asthma and COPD show up on spirometry and what numbers we use to make these diagnoses. I'm going to go over this a couple of times. But first off, both asthma and COPD are obstructive diseases. That means patients have trouble getting air out of their lungs. And on spirometry, we'll see this as a reduction in their FEV1 and FEVC ratio. But there are some key differences that we use to kind of distinguish the two between. Okay, so asthma, according to the GINA guidelines, we characterize asthma as a reversible airway obstruction. Patients have symptoms that are vary over time. They're often triggered by things like our allergens, exercise, walking out into cold air. We can kind of trigger that kind of inflammation and spasm in that airway. On spirometry, we might see some low FEV1. We might see a low ratio. But the critical point here that I want you to get is with asthma, we're going to see an improvement with the use of a bronchodilator. So we do that post bronchodilator test, and we see an improvement. An improvement's defined as 12% of an improvement or more than 200 mils of an increase in that FEV1. So that volume that they can get out in 1 second improves by 12% or 200 mils from their baseline. And that's our gold standard to demonstrate reversibility. Okay. And that's when we say, okay, this looks more like asthma than COPD. However, if we have obstructive findings and it doesn't improve, we think of the COPD in the GOLD guidelines. So COPD is a little different. It's chronic, progressive, and not fully reversible. Okay. We may see some improvement with a bronchodilator, but we're likely not getting that 12%. Okay. Because it doesn't have the same pathology that asthma has. And sometimes people have both, right? Asthma and COPD, that's possible. But we think of the history, we think of context, we think of age, we think of a COPD. Did they smoke? Did they have some like long-term exposure to different harmful irritants to the lungs? But when we think of our spirometry, our key finding is even after we do the bronchodilator test, we're really looking at the ratio, and the ratio remains below 0.7, which I'll show you a slide here in just a moment. That post-bronchodilator ratio is really what confirms the diagnosis more of COPD, okay, versus asthma. Like I said, we may see some improvement. So in short, asthma, reversible obstruction, more than 12% improvement post-bronchodilator, COPD, irreversible obstruction, right? We can see a little improvement, but not much. And we're looking at the ratio, which is less than 0.7. Both conditions, again, overlap, especially in older adults. if you have complex or unclear cases, or if you think there could be some restrictive aspect to their lung disease, we're going to refer those guys out to pulmonology for our specialty tests, and then maybe we can co-manage, right? So that's kind of the thought there. Okay, so COPD, classified as a group of obstructive lung diseases characterized by cough and increase in shortness of breath. Some of the causes we kind of talked about: smoking, pollution, the environment. Research is kind of showing us some genetics, socioeconomic status also play a role, probably that epigenetic stuff that we've been hearing more and more about. And then we think about bronchitis and emphysema. We really think about the difference between, and how do we distinguish some of these different things, and what would we see on in the imaging, and how would it kind of change our treatment. So chronic bronchitis versus emphysema. Think of chronic bronchitis as the two major kind of categories of COPD, or that obstructive pulmonary disease. COPD is kind of an umbrella term. You can think of it as chronic bronchitis as like the airway disease, and emphysema as the alveolar or the parenchymal disease. Most patients will have both, or will develop both features, but one will be kind of predominant in that patient. So chronic bronchitis, defined clinically as a productive cough for at least 3 months in 2 consecutive years. Pathology really involves mucus overproduction and inflammation of those bronchial tubes. These patients are often cyanotic, frequent infections. They may have a little bit of overweight. This is kind of called the blue bloaters. When on X-ray, we'll often see kind of normal early on. We might see a little bit of increase in that bronchovascular markings. We could see an enlarged cardiac silhouette due to that core pulmonal. Possible flattening of the diaphragm in advanced disease. And emphysema, on the other hand, is more of that destruction of those alveolar walls. So we see kind of permanent enlargement of those spaces, inability to kind of contract. So we get air trapping in emphysema, reduced gas exchange, and that hyperinflated lung in these folks. We think of these guys looking a little bit more thin, a little dyspneic. You might have that pursed lip breathing, and we think of these guys as the pink puffer. It's like those two terms that people use. I don't really use those, but that's one thing that I do recall learning about to kind of help distinguish the difference here. Emphysema is really one of the main forms of COPD, structural diagnosis, where bronchitis is more of a clinical diagnosis, and they both result in that kind of irreversible airflow limitation. And again, we're confirming it with that post-bronchodilator of the ratio being less than 0.7. When we're thinking about these things, that's just kind of how I want you to go through it. All right. Manifestations of COPD: cough, mucus production, wheezing, history of frequent respiratory infections, and activity intolerance. Our diagnosis, again, less than 70, our FEV ratio. I'm not going to go into all of our scoring, but know that gold has the scoring. We have mild, moderate, severe, and very severe. And then we have groupings A, B, and E. We like to think of these different things because it helps guide our treatments. All right, so if we have group A, we're thinking of bronchodilator, group B, a LABA plus LAMA, and group E, we're thinking LABA, LAMA, and then an inhaled corticosteroid. That is why we do it, and then we're going to always review, assess, and adjust treatment as needed, because we might go up or down depending on where they're at. Okay, we want to consider for any sort of exacerbation, we will kind of follow this little bit of a guideline. So it's kind of that short-acting corticosteroids, likely systemic, 5 to 7 days. Antibiotics, maybe. I'm curious as information keeps coming out on the value of antibiotics at this point, and then hospital admission if needed. Okay, again, here we use that gold. If you don't have a copy of this, I would recommend getting a copy of this. Okay, asthma, very, very quickly. We have our GINA guidelines. We have reversible disease. That's what we see in asthma. We have our symptoms: cough being kind of the common one, a dry kind of cough, worse at night, maybe waking up in the middle of the night, trouble with exercise, allergies. eczema, we see that kind of triad of things occur together. I often think we see this usually kind of present itself in childhood, although some adults can present with asthma. Um, and I would guess that's more through that epigenetic kind of presentation, where you have environmental stimuli that are kind of turning on certain genes, likely. We classify it as intermittent, mild, moderate, or severe. We use these rule of tools when we're thinking about it. So how often are they waking up? How often are they having symptoms? How often are they using their inhalers? And that is how we go ahead and diagnose it. Okay. So intermittent, we're not using to, we don't, it's pretty kind of like we can say when it's going to happen, right? Like exercise or something like that. Mild, we're starting to have symptoms a little bit more. We're waking up a little bit more frequently with some shortness of breath. Moderate, we're, waking, at least once a week, and we're starting to see some impact in our daily life. Severe, constant daily symptoms. Okay, we think we can also use our spirometry to help classify as well. So here's what we're going to do. We're going to use context, and we're going to also use spirometry results to decide where does our patient fall. And the reason why classification matters so much is because we use classification to determine what our treatment is, and we're going to use a step up or step down approach. Okay, so we talked about our spirometry. We're thinking that reversibility, and that tells us that it's asthma versus a COPD, and also context, clinical context, asking questions, asking about the history. And then we have our steps here, okay? Take a photo of this, know this for your exam. This is very, very important that you understand that we have changed since when I was in school, how we address asthma. This is for adults and adolescents over 12, okay? Our first starting in intermittent asthma, we're already bringing in the steroids. We know that this is an inflammatory disease. We are no longer waiting. We used to use just albuterol, not the case anymore. Now we're just going ahead using a long-acting beta agonist along with an inhaled corticosteroid, and we use it as needed during intermittent. We're just going to increase the frequency of that or the potency of the inhaled corticosteroid based on the severity and the step that they're at. Okay, so just if you can understand where they're at, this is how I would approach asthma, is understanding how do I diagnose it and classify them, and then knowing what classification requires what treatment step. Okay, they've made it so much easier than what it used to be. We can now go ahead and we have that smart kind of situation where we can use that same inhaler for both maintenance and rescue. So we no longer have to be fumbling and having all these different inhalers around. We just prescribe one inhaler with a combined product, and they use that depending on how they're feeling. And they can use it every day or as needed, or every day and as needed. Okay, that's what we're doing. And then we start adding things on. When I'm adding things on, when I'm not controlled at a medium dose, I'm starting to kind of consult with pulmonology on these cases. Also, if they're young, um, if they're less than 5, I'm not seeing them. They're going to be over a children's likely. But if they're about 5, here's a little bit different. So here we go kind of to step 2. So on an intermittent asthma, we do a low dose ICH every time we use a SABA. Okay. Then we just kind of see this. It's kind of a little bit like what we used to do with adults is what we're doing with kiddos at this point. And our rescue inhaler is that short acting for symptoms. Or in steps 3 and 4, then we could use the same one. So now we have to come all the way down here to use the same one. However, in adults, we got to use that same rescue inhaler. Okay, so that's that smart therapy, using the same inhaler for rescue and maintenance. Okay, I appreciate it. I'm sorry I ran over and we didn't have time to go over our case study. It was just an asthma patient, which kind of was a different presentation, a 32-year-old, 6-month history of intermittent wheezing, chest tightness, shortness of breath, starting to have increase in frequency. Okay, so we did some spirometry. We understood that her FEV1, and we saw improvement. So we're going to go ahead and we're going to put her on the GINA guidelines, and we're going to decide based on that what we're going to do. But with adults, it's so great. We put her at step 3 based on all of the presenting factors, and we went ahead and chose the budesonide formoterol, the Symbicort, which is a moderate dose of those steroids. And that's where we see that kind of happening at that point. And we're going to use this same inhaler for rescue as we do for maintenance. We're going to see them back in about 1 to 3 months, and then retest their spirometry and understand if we see improvement in that right? So they should kind of have pretty normal lung function if we're doing our job with the medication correctly. If not, then we need to consider stepping up our treatments. All right. Some folks like to use diaries. That's not wrong. Do you guys have any questions? I can hang around here. I appreciate you hanging out with me a little bit longer. I know I'm get chatty and get way over on some of these things. But if you do want to go over this, I will be talking about asthma again and COPD with a little bit more time in our 3-day live review here at the end of the month. Um, okay, so if you missed it, go ahead, scan this QR code, sign up. I would love to see you on May 28th. I will be doing GI, respiratory, and musculoskeletal lectures, and then Hiva's hitting our cardiac, which is amazing if you haven't seen her present on that. And then we have lots of other folks that will be joining us to give amazing, amazing lectures, guys. These are really experienced nurse practitioners coming in to give you the best. And we have a few professors that are on staff now. It's amazing. So if you are not, please join us if you're getting ready for that boards test. Okay, it's been a pleasure. I hope this was helpful and best of luck. Remember, when you're taking your exam, deep breaths and really just try and remain as confident as possible, and you'll do great. Okay. If you have a minute, pull your phones back out. I just need this confidence scoring pre and post lecture. Do you feel a little bit better about, examining patients with respiratory conditions after today's 1 hour? I know it's not amazing time. You could spend hours and hours on this stuff, but hopefully it just built up your confidence just a little bit. Awesome. All right. Anybody else able to just click on this QR code for me? Awesome. Okay. Thanks, guys. I appreciate it. And I had one person in the chat here. Let me see. Yes, Tracy, you're welcome. And if you guys have any other questions, please don't hesitate to contact us at that nurse practitioner. Tracy, you can email specifically. I'm not sure. I think we're kind of waiting to see kind of the traction that we get on this 3-day live review, but much better. Wonderful, Malin. That's great. All right, everybody, have a wonderful rest of your week. And thank you so much for joining us. And if you have any questions whatsoever, don't hesitate to reach out. Awesome. Bye. Bye, guys.